Some interesting perspectives on this landmark cross trial. 75% of the trial population were adenocarcinomas. 80% of the trial population were distally located, either in distal one third or GE junction. Patients with reasonably good performance status, non bulky, non T4 tumors, randomized to one of the two arms. Surgery alone in one arm, the cross arm, NACT-RT followed by surgery. Please note that either a transhiatal esophagectomy or a two-field TTE were accepted in the trial. Established safety of this protocol by an impressive treatment completion rate of 91% without serious adverse events. Established efficacy by PCR rates approaching 49% for squamous cell cancers and survival benefit at all landmark time intervals, the cross arm experiencing a consistent and a persistent survival benefit which was seen even at 10 years of follow up. Please note, the survival benefit was not seen only in SCCs. Both adenocas and SCCs had survival benefits, but the magnitude of benefit was higher for squamous cell cancers. It's common it's a common misconception during early residency that for squamous cell cancers of esophagus, NACT-RT is better than NACT because of this impressive PCR rate and the survival jump. This was not the question in cross. This was not the comparison in cross. What cross actually showed was if we give neoadjuvant chemoradiation to both squamous and adeno, both will respond, both will have a survival benefit. The magnitude of benefit is higher for squamous. The reason for this video is this interesting concept of the mechanism by which neoadjuvant chemoradiation improves survival in esophageal cancers and more so in squamous cell cancers. Broadly, cancer directed therapy can be divided into treatment of the primary and the locoregional lymph nodes. That's a locoregional therapy in the form of surgery, radiation, or ablative therapy. And the other one is systemic therapy. There are multiple well understood logical reasons for giving a neoadjuvant systemic therapy before a local therapy, a locoregional therapy in the form of surgery. These are all self explanatory. But why will we consider one locoregional therapy before another locoregional therapy? Amongst all the cancers in the body, the pink ones preferably being treated with definitive chemoradiation, hypopharynx, larynx, and cervix, either definitive chemoradiation or surgery, depending on a lot of reasons. Let's focus. There are only two cancers in which one locoregional therapy of radiation is offered before the locoregional therapy of surgery: esophagus and rectum. So, what is so unique about these two cancers and what is common to them? It's their sheer anatomical location. If you think about the rectal cancer, the narrow confines of the pelvis, poor visualization before the minimally invasive surgery era, led to a lot of locoregional recurrences, which were reduced by the concept of total mesorectal excision. Surgeons started doing total mesorectal excision. Even then, the locoregional recurrence rates were high. It was because the mesorectum contains only the superior mesorectal nodes. Nodes, the draining nodes for the mid and lower rectum are in the internal iliac chain, the lateral pelvic nodes. So even after a TME surgery, locoregional recurrence rates were happening because of the lateral pelvic nodes. So that is when neoadjuvant chemoradiation followed by a TME surgery significantly reduced the locoregional recurrence rates. But unlike the rectum, in which there is a well defined anatomical fascia called the mesorectal fascia, there are two problems in esophagus. There is no well defined fascia like that. And the pattern of lymphatic metastasis is more erratic than that of rectal cancers. Embryologically, the proximal esophagus, deriving its blood supply from the bilateral inferior thyroid arteries and bronchial arteries, is expected to drain its lymphatics to this area, these areas around the recurrent laryngeal nerves. The space marked in yellow is called as the visceral space, which is believed to contain all the draining lymphatics from the esophageal cancers. But this is not an anatomical space like the mesorectal fascia. This is an imaginary space. And as you can see, the imaginary space includes the bilateral recurrent laryngeal nerves. Because of the extensive submucosal lymphatics, tumors in any location of esophagus can have lymphatic metastasis in any sites of the mediastinum. So the main problem in esophageal cancer are these anatomical constraints and the presence of lymph nodes in this superior mediastinum around the recurrent laryngeal nerves. Similar to rectum, with the advent of minimally invasive surgery, the improved magnification and the visualization and the precision, the nodes around the recurrent laryngeal nerves can be dissected safely while preserving the recurrent laryngeal nerves, because injury to recurrent laryngeal nerves after an esophagectomy is extremely morbid. Before the minimally invasive surgery era, we know that finding the RLN in the neck during a thyroidectomy may sometimes get difficult. Imagine a surgeon standing here, a thoracotomy in the fourth or fifth intercostal space. This is the exposure after the thoracotomy with its constraints of illumination and exposure. The surgeon has to remove the lymph nodes around the recurrent laryngeal nerves without damaging the RLN. Imagine how difficult it would have been. It was obvious that this procedure was feared because it was fraught with complications of RLN palsy. So the reason for such extensive debates about whether complete mediastinal lymphadenectomy has to be done, whether it offers any survival benefit at all, is all because the morbidity of RLN palsy is too high post esophagectomy. In the cross trial, as because the bulk of the tumors were in the lower one third and they were all adenocarcinomas, it is assumed that total mediastinal lymphadenectomy was not done. The exact number or whether complete superior mediastinal lymphadenectomy was done is not clear, it's not mentioned anywhere. The median lymph node yield is 15 to 18, and 45% of the trial population actually underwent a transhiatal esophagectomy. So the Far East believes that the survival benefit of this cross trial was merely because of the less radical lymphadenectomy. It's like the radiation in some way compensated for the lack of extensive lymphadenectomy. This is the Eastern way of thinking. And in the actual 10-year follow up of the original cross trial, so this is from the cross trial long term follow up, we can see that the rates of isolated distant metastasis is not different between the two arms at all. For a patient who undergoes an upfront surgery and surgery alone, and for a patient who undergoes a neoadjuvant chemoradiation, the rates of isolated distant metastasis, the chances of the patient failing in the lungs or liver or anywhere else is the same. The only difference was seen in the locoregional recurrence rates. Locoregional control was higher in the patients who underwent the cross protocol. Locoregional plus systemic. So this improved locoregional control and reduced locoregional relapse is believed to be a strong reason for the improved survival, because Despite not clearing the nodes in the upper mediastinum, these patients experienced a decreased locoregional control because of the radiation effect on these nodes. It is very important to remember original words from the cross protocol itself. The chemotherapy administered during the cross protocol, that is, these 5 cycles of paclitaxel, is very similar to the capecitabine given along with the long course chemoradiation for rectal cancer. It is a purely radiosensitizing dose. It is not the cytotoxic dose. So this the cross protocol does not offer an early systemic control and a local control because it has both chemotherapy and radiotherapy. It's important to understand that the survival benefit is seen mainly because and only because of the improved locoregional control. The chemotherapy is purely a radiosensitizing dose. So now, if we want to improve the systemic control better, we need further better systemic therapy. This was again original words from the cross trial 10-year follow up publication. A very similar concept is what is seen in rectum. If you understand, people were doing rectal cancer surgeries, locoregional recurrences were happening. Health introduced TME, they started doing TME surgeries, locoregional recurrences decreased by 50%, but they were still happening. Then they understood that lateral pelvic nodes could be a reason. NACT-RT plus TME surgery, locoregional recurrence rates even reduced by half, 50%. And now the use of MRI to accurately map the disease on the seminal vesicle, prostate, presacral fascia, the use of extended TME to include those diseased areas after neoadjuvant therapy if required, the use of minimally invasive surgery to improve visualization in that narrow pelvis, especially robotic, the use of neoadjuvant chemoradiation to tackle all this, the combination of all these things has now significantly reduced the locoregional recurrences. So this is what is happening. Now the problem with rectal cancer is only distant recurrences. So then came the concept of total neoadjuvant therapy. We'll do all this. We'll do MRI. We'll do extended TMEs if required. We'll give neoadjuvant chemoradiation. We'll do all that so that local regional control is achieved. But we are still failing distant sites. So we need chemotherapy also before surgery. So that thus came the concept of TNT in rectum. So very similarly, esophagus also. So it is likely to happen, but not anytime soon. It has to be understood that the main mechanism of action of cross was the improved local control, and the chemotherapy is a purely radiosensitizing dose. So the two broad philosophies of treating squamous cell cancers of esophagus, which have a very high likelihood of metastatic lymph nodes in the superior mediastinum. The Far East, especially the Japan, even after the publication of Cross, never took up chemoradiation. We all know them to be radical surgeons across all subsites of cancers. So their main aim is to reduce systemic failure. They were using neoadjuvant chemotherapy as per their JCOG 9907. And now with the publication of next trial again from Japan, they have they are still continuing to use NACT alone. Next is a very interesting trial in which they have proved head to head that NACT with a triplet chemotherapy is actually better than neoadjuvant chemoradiation for squamous cell cancers of esophagus. We'll discuss next in another subsequent video. So, so the Far East believes that systemic control with NACT followed by an aggressive surgery for locoregional control, en bloc removal of all superior mediastinal lymph nodes with a complete mediastinal lymphadenectomy is the ideal way of treating squamous cell cancers of esophagus. The rest of the world, the West and India, in majority, believe that MDT multidisciplinary treatment is the way to go, with the use of neoadjuvant chemoradiation in an attempt to sterilize these lymph nodes. In very simple terms, to just help in understanding, to compensate for the less radical lymphadenectomy in this area, followed by a standard intracarinal lymphadenectomy, esophagectomy, is the philosophy in the rest of the world outside the Far East.